Hello everyone, I am myself Dr. �‌𝐼𝐳𝐽𝐽. I am the general medicine educator. So in this particular section, I'll be discussing the multiple choice questions in the topic of the nephrology. So the topics on which I'll be discussing is on the acute kidney injury, then the questions on chronic kidney disease, diabetic nephropathy, renal stones, kidney and urine analysis, nephritic and nephrotic syndrome, renal artery stenosis, renal tubular acidosis, and then syndromes which are associated with the kidney. So let me take up the first question. Which of the following complication is most likely to develop in a patient with chronic kidney disease which is classified as grade 4? Hypertension, anemia, hyperkalemia, and then the uremia. So you take this CKD, we have totally 5 grades, grade 1, 2, 3, 4, and then 5. So there are totally 5 grades in the chronic kidney disease. And in grade 1, so how is this grades being done? Based on the GFR. So in grade 1, the GFR is more than 90 ml per minute per 1.73 meter square. Then you reduce it by 30. In grade 2, it is 60 to 89 ml per minute per 1.73 meter square. Then in grade 3, GFR is 30 to 59 ml per minute per 1.73 meter square. And in grade 4, the GFR is 15 to 29 ml per minute per 1.73 meter square. Whereas in grade 5, this is called as end-stage renal disease, where the GFR will be less than 15 ml per minute per 1.73 meter square. So this will be the grades in case of chronic kidney disease. Now, in case of grade 1, there is a kidney damage, but the GFR is still being maintained. Whereas in grade 2, these patients, there is a scope for the development of the hypertension, right? Whereas in grade 3, these patients will develop anemia. In grade 4, there will be electrolyte abnormalities, and that electrolyte abnormalities will be in the form of hyperkalemia, and there will also be metabolic acidosis, right? There will be metabolic acidosis, and that is due to loss of bicarbonate and decreased excretion of ammonia. And in grade 5, these patients will have the features of the uremia, that is uremic encephalopathy, then pericarditis, pleuritis, then gastroparesis, band keratopathy, �̑𝐺erosis, and peripheral neuropathy and genitourinary abnormalities. So these will be the features that you will have in case of end-stage renal disease when the GFR is less than 15 ml per minute per 1.73 meter square. Now, so the answer in this question is, so the question asked is grade 4. So in grade 4, the electrolyte abnormality that these patients will develop is hyperkalemia. Okay. So hypertension, it is observed in grade 2, anemia grade 3, then uremia grade 5, hyperkalemia you will have in case of grade 4. And the other part of the definition of chronic kidney disease is, apart from the GFR, even albuminuria. So based on the albuminuria, we classify the CKD into A1, A2, and as well as A3. So A1 is that where the albuminuria is less than 30 milligrams per gram of creatinine. A2 is 30 to 300 milligram per gram of creatinine, and A3 is more than 300 milligram per gram of the creatinine. Okay. So this is about the chronic kidney disease staging, definition, and as well as what are the metabolic abnormalities depending upon the staging, right? Then next question, pick the option with appropriate statements regarding allogenic renal transplantation. The options are prior Doppler showing unilateral renal artery stenosis in the donor is the contraindication. Right kidney of the donor is used. The donor's kidney is placed in the right iliac fossa of the recipient. In recipient with 1/6 HLA anti-CD25 molecule is used for induction. So which points are correct statement here? So the correct answer is your prior Doppler is very much required in the donor. If there is unilateral renal artery stenosis, it's a contraindication for donating the kidney, because if there is unilateral renal artery stenosis, if you take out the normal kidney, the kidney which is having renal artery stenosis will have the greater chance of the renal failure in the progress of the patient or in the progress of the donor. So unilateral renal artery stenosis is a contraindication. And right kidney of the donor is used? No, it is the left kidney of the donor that is being taken. Why? Because of the longer renal vasculature, right? And next is the donor's kidney is placed in the right iliac fossa of the recipient is a correct statement. It is placed in the right iliac fossa, right? So not in the loin area. We place it in the right iliac fossa itself. Then in recipient with 1/6 HLA match, the anti-CD25 is used for the induction. That is a wrong statement. So we use the anti-CD25 when the HLA is like 2/6 or 3/6, right? When HLA is 2/6 or 3/6, then we use this particular anti-CD25, right? But not for 1/6. So you need to give induction therapy in order to prevent the graft rejection. After the induction therapy, you need to give the immunosuppressant drugs, and these immunosuppressant drugs include cyclosporin, azathioprine, and as well as prednisolone. That has to be given in order to prevent the graft rejection. But whenever you are giving these immunosuppressants, there is high chance of the opportunistic infections, and these opportunistic infections include methicillin-resistant Staphylococcus aureus, hepatitis B virus infection, polyoma virus infection, then pneumocystis jirovecii pneumonia infection, and then the next one is the aspergillus infection can be there. Okay, so the correct answer here is A and C only. All right, next question. Which of the following is not true regarding the procedure shown in the image? The options are refractory acidosis is an indication for this therapy. That is the first option. The presence of bruit indicates the damaged fistula. The principle is diffusion followed by the ultrafiltration. Seminobraccia fistula is placed between the radial artery and as well as the cephalic vein. So the point is, which is the not the true statement. Refractory acidosis is an indication for this hemodialysis. That is a correct statement. What are the indications for the hemodialysis specifically? That includes number 1, refractory hyperkalemia, right? Then refractory acidosis. Then refractory volume overload, not responding to the diuretics and as well as not responding to the fluid restriction as well. Next, elevated blood urea nitrogen, and that should be more than 35 millimoles per liter. Then pericarditis, uremic pericarditis. Okay, then followed by that edema, that is pulmonary edema is also an indication, right? And followed by that, the next important is encephalopathy. That is uremic encephalopathy is also an indication for the hemodialysis. So the first A point is correct. And the presence of bruit indicates the damaged fistula. This is not the true statement. Actually, the presence of the bruit, so what is the bruit that you will have is, that is the presence of the continuous murmur, right? The presence of the continuous murmur over the fistula, it indicates that the fistula is functioning. That indicates that the fistula is functioning. Okay. Next, the principle is diffusion followed by ultrafiltration. That is a correct statement. All right. Then seminobraccia fistula is between radial artery and as well as the cephalic vein. That is also a true statement. And why is this fistula created? The fistula is created because there will be reduced incidence of thrombophlebitis. Okay, so there is reduced chance of thrombophlebitis. That is the reason why the fistula is created between the radial artery and as well as the cephalic vein. Okay, so the one which is not the true statement is the B is not the true statement. And what is the most common complication associated with the hemodialysis is hypotension. And there is loss of certain vitamins when doing hemodialysis, that is pantothenic acid is being lost, and thereby the individual will develop burning feet syndrome. Okay, and apart from this, during this particular hemodialysis, another very important point that you need to know and you need to remember is that amyloid beta 2 protein is not excreted out during hemodialysis. This amyloid beta 2 protein that will accumulate in the brain, resulting in dialysis dementia, and this amyloid beta 2 protein, it will accumulate over the flexor retinaculum, resulting in the carpal tunnel syndrome. All right, so the next question. So after having discussed about the questions related to the chronic kidney disease, now let me take up the questions related to the acute renal failure or acute kidney injury. Which of the following drug leads to non-oliguric renal acute kidney injury? So normally in case of acute kidney injury, you will have oliguria first, where the urine output will be less than 400 ml per 24 hours. And then followed by that, there will be anuria. So anuria is that where the urine output is less than 100 ml per 24 hours. That is what is nothing but your anuria. Now, there are certain etiologies where there will be non-oliguric renal acute kidney injury, where the patient will have the polyuria, right? Where these patients will have polyuria, all right? Now, what are those etiologies where it can cause polyuria in spite of acute kidney injury is amphotericin, cisplatin, gentamicin, and as well as the cyclosporin. So actually there are two answers here, but the best answer will be gentamicin, which is nothing but the aminoglycosides. These aminoglycosides, they will damage the V2 receptors, and that will result in nephrogenic diabetes insipidus. So there is no water reabsorption at the level of the distal tubules, so the water is excreted out in the form of urine in excess quantity, where these individuals will have the polyuria, all right? And amphotericin B is another important drug which can cause non-oliguric acute kidney injury, all right? Next, cisplatin and as well as cyclosporin, which will cause acute tubular necrosis, where the individual will have the oliguria and followed by that the anuria. And all these drugs, the type of acute kidney injury, what these will cause is the intrinsic type of acute kidney injury. Acute kidney injury, we classify the etiology into pre-renal, intrinsic renal, and post-renal. So pre-renal is that where perfusion to the kidney is reduced. Intrinsic renal is that where pathology is within the kidney, and most common causes include like glomerulonephritis or acute tubular necrosis. Post-renal is pathology is outside the kidney, like ureteric calculi, bladder malignancy, benign prostatic hyperplasia, right? So these are, and next bilateral ureteric fibrosis, which is caused by your bleomycin. These are all the etiologies which will contribute to post-renal type of acute kidney injury, all right? So the answer here is the gentamicin, right? Next question. Which of the following stages of acute kidney injury presents with a serum creatinine 2.5 milligrams per deciliter and urine output below 0.5 milligram per kg per hour over the past 12 hours? The options are stage 1 acute kidney injury, stage 2 acute kidney injury, stage 3 and stage 4 acute kidney injury. So please remember that the acute kidney injury network criteria, this is the organization which has given the staging of the acute kidney injury, right? This has given the staging of acute kidney injury, but it has divided the acute kidney injury only into 3 stages, that is stage 1, stage 2 and as well as stage 3. So in case of stage 1, right? So in case of the stage 1, how much will, so there will be based on increase in the severity of serum creatinine, and based on decrease in the urine output, the stages are being divided. So you take in case of stage 1, the increase in serum creatinine will be 1.5 to 1.5 times the normal value, whereas you take in case of the stage 2, the serum creatinine is increased 2 to 2.9 times the normal value, whereas in stage 3, the increase in serum creatinine will be more than or equal to 3 times the value of the normal. So that will be increase in serum creatinine in stage 1 to 3, whereas how much will be the decrease in urine output is, it is less than 0.5 ml per kg per hour for nearly around 6 hours, whereas in stage 2 the urine output will be the same, but it will be for nearly around 12 hours, whereas in stage 3 the urine output will be less than 0.3 ml per kg per hour for nearly around 24 hours, right? For nearly around 24 hours. Okay, so this is about how we do the staging. Now in the question which has been given to you, the decrease in urine output is less than 0.5 ml per kg per hour over 12 hours. So this is coming under the stage 2 acute kidney injury, right? This is coming under stage 2 acute kidney injury, all right? Next question. Now the next question is based on diabetic nephropathy. Which of the following is the best management for diabetic nephropathy patient with an estimated GFR of 25 ml per minute per 1.73 meter square and currently on metformin and glipizide for glycemic control? The options are continue metformin and glipizide at the current doses, discontinue metformin due to reduced kidney function, then discontinue glipizide due to reduced kidney function, initiate linagliptin for better glycemic control. So how much is the estimated GFR? Estimated GFR is 25 ml per minute per 1.73 meter square. Now you cannot continue metformin because the metformin is associated with important adverse effect called lactic acidosis. And when the estimated GFR is less than 30, you need to stop metformin, otherwise there can be precipitation of lactic acidosis. So continuing metformin is completely wrong option. Then discontinue metformin due to reduced kidney function, that is a correct statement, alright. Then discontinue glipizide due to reduced kidney function. So let me tell you, in spite of renal failure, the oral hypoglycemic agents that can be given in the treatment of diabetes mellitus is, you can continue glipizide, right? And if the patient is not willing to take insulin, then you can give linagliptin, right? Then you can give linagliptin. Otherwise, in patients with diabetic nephropathy, the best drug to control the blood glucose will be insulin. Insulin is considered as the best drug. And even insulin also, you cannot give full dose because insulin gets excreted through the kidney, and when there is renal failure, the half-life of the insulin increases. So what you have to give is only 80% of the calculated dose of the insulin has to be given in case of renal failure, so that the half-life of the insulin increases, okay? Why? Because the half-life of the insulin is increased, and if you give full dose, there is chance of hypoglycemia. That is the reason why you should give only 80% of the calculated dose. So discontinue linagliptin due to reduced kidney function? No, you can continue glipizide, no problem. Now initiate linagliptin for better glycemic control. Actually, you can give linagliptin, but for better glycemic control, the drug of choice will be the insulin. It is not the linagliptin. So that is the reason why the better or the best management will be discontinue metformin due to reduced kidney function, because there can be precipitation of the lactic acidosis in this patient. Alright. Next question. A 60-year-old male with long-standing history of poorly controlled type 2 diabetes mellitus presents to the nephrology clinic with worsening kidney function. His serum creatinine levels have been gradually increasing over the past year. What histopathological finding is most characteristic in this patient associated with the development of nodular glomerulosclerosis? Diffuse glomerulosclerosis, Armani-Epstein change, 𝐒𝐮𝐬𝐜𝐫𝐢𝐛𝐞 change, damage to the distal convoluted tubule, right? So now this particular patient has developed nodular glomerulosclerosis. This patient has developed nodular glomerulosclerosis. Now, in case of nodular glomerulosclerosis, the characteristic histopathological finding, right? The characteristic histopathological finding will be the 𝐒𝐮𝐬𝐜𝐫𝐢𝐛𝐞 lesion. So, 𝐒𝐮𝐬𝐜𝐫𝐢𝐛𝐞 lesion, this is also called as intercapillary glomerulosclerosis. Right? It is also called intercapillary glomerulosclerosis. So, in case of diabetic nephropathy, there are two important changes. One is diffuse glomerulosclerosis and the other one is nodular glomerulosclerosis. Diffuse glomerulosclerosis is more common than nodular glomerulosclerosis. But in diffuse glomerulosclerosis, the earliest finding will be thickening of the basement membrane. And there are two important lesions or exudative lesions that you will have. One is the fibrin caps, right? And then the other important glomerular or the other important exudative lesion along with the fibrin caps will be the drops, right? That is the eosinophilic drops that will be there. Whereas pathognomic for diabetic nephropathy will be nodular glomerulosclerosis, and these nodular lesions, they are called as the KW lesions, okay? Whereas the most common will be definitely diffuse glomerulosclerosis. Then what is this Armani-Epstein change? Armani-Epstein change is that when the blood glucose levels are more than 500 milligrams per deciliter, then the glucose gets accumulated within the PCT cells in the form of glycogen. Right, the glucose, it is accumulated in the PCT cells in the form of glycogen. So that is what is called as the 𝐒𝐮𝐬𝐜𝐫𝐢𝐛𝐞 lesion, right? So this is about your answer of nodular glomerulosclerosis, which is nothing but your KW lesion or the intercapillary glomerulosclerosis, all right? So after having discussed about the questions related to the diabetic nephropathy, the next topic for the discussion would be the renal stones. So if you see the questions on the renal stones, we have a 40-year-old male patient with history of recurrent kidney stones, gross elevation in 24-hour urine calcium levels, and the presence of the envelope-shaped crystals in his recent urine analysis. What treatment options should be considered for this patient? Thiazides, normal calcium diet, sodium reduction in the diet, and then the furosemide. So what treatment option should be considered for this patient? So the patient is having the envelope-shaped crystals. The presence of the envelope-shaped crystals, it is suggestive of the hypercalciuria. Okay, and this hypercalciuria will result in the calcium oxalate stones. Right, will result in the calcium oxalate stones. Okay, so calcium oxalate stones are the one which will give rise to this envelope shaped crystals. Okay, now what should be considered for reducing this calcium in the tubule is thiazides. So thiazides are considered effective in preventing the recurrent kidney stones, especially in patients with hypercalciuria. Why? Because this particular thiazides will reduce, right, will reduce calcium excretion in renal tubules. Okay, will reduce the calcium excretion in the renal tubules. Okay, so the answer here is thiazides. All right, and the most common cause of calcium oxalate stones, it is idiopathic. Like, we don't know what exactly is the cause. Whereas you take this furosemide. Furosemide is a loop diuretic. It is contraindicated with hypercalciuria. Why? Because this furosemide will increase the urinary calcium excretion. Right? Will increase the urinary calcium excretion. Now, when it is increasing the urinary calcium excretion, there is a potential that there is exacerbation of the kidney stone formation. That is the reason why it is not appropriate treatment option for preventing the recurrence of kidney stones in this population of the patients where there is recurrence. So in recurrent kidney stones, the drug that can be given is thiazide diuretics, which will prevent the recurrence. All right. Next question. A 40-year-old woman presents to the urology clinic with complaints of recurrent episodes of flank pain and difficulty in passing the urine. Upon further inquiry, she mentions a history of the hyperparathyroidism, right, diagnosed 5 years ago. Urine analysis reveals the presence of rosette-shaped crystals on the microscopy. What is the most likely cause of the patient current symptomatology? The options are the uric acid stones, calcium phosphate stones, struvite stones, and cystine stones. So what is there? There is presence of rosette-shaped crystals. So presence of rosette-shaped crystals, that is suggestive of the calcium phosphate stones. So the patient is having history of hyperparathyroidism. There is chronic gastrointestinal issues, that is suggestive that there is a potential disturbance in the calcium and phosphate metabolism, resulting in the formation of the calcium phosphate stones. Okay, and these patients with hyperparathyroidism, they cause hypercalcemia, which increases the risk of the calcium phosphate stones, right? So, and this, in what will be the shape of these calcium phosphate stones? The shape of these calcium phosphate stones will be a rosette shaped crystals. Okay, whereas you take these uric acid stones. Uric acid stones, they are typically associated with clinical conditions such as gout, not in the scenario of the hyperparathyroidism. And you take this struvite stones. These are associated with urinary tract infection. These are associated with urinary tract infection, and they are typically composed of magnesium ammonium phosphate. Right? They are typically composed of magnesium ammonium phosphate. Okay? And this particular patient does not give any history of urinary tract infection. That is the reason why your struvite stones are ruled out. Then coming to the cystine stones. These cystine stones, as such, these are rare. And they are typically seen in patients with cystinuria. Right? They are typically seen in patients with cystinuria. And cystinuria is what? It's a genetic disorder characterized by defective renal tubular reabsorption of cysteine. Okay? And the cysteine which is not being reabsorbed, that will get accumulated within the tubule, resulting in the formation of the cystine stones. Okay, so the answer here is calcium phosphate stones, which is very common in patients with the hyperparathyroidism. Okay, so that was about the questions on the renal stones. The next question is on the kidney urine analysis. Now, what is the approximate protein concentration in patient's urine if proteinuria in dipstick shows 3+? 15 to 30 milligrams per deciliter, 30 to 100, 100 to 300, and 300 to 100 milligrams per deciliter. So this is a very, very important previous year question. So like how this urine dipstick test will give the valuation of the protein as trace 1+, 2+, 3+, and 4+. Now, when do we use the term trace? We use the term trace when the urinary protein is around 15 to 30 milligrams per deciliter, and we use the term 1+ when the urinary protein is around 30 to 100 milligrams per deciliter, and we use the term 2+ when the urinary protein is around 100 to 300 milligrams per deciliter, and we use the term 3+ when the urinary protein is 300 to 1000 milligrams per deciliter. Then if the urinary protein, if it is more than 1 gram, right, if the urinary protein is more than 1 gram, then we use this term as the 4+, right? We use this term as the 4+. So this is how the dipstick test results are being interpreted, right? So now what is our question? 3+. So 3+ is what now? That is 300 to 1000 milligrams per deciliter is what is nothing but your 3+. Okay. Next question. All of the following cause pink or the red color urine except porphyrin, rifampicin, clofazimine, chloroquine. So porphyrins, rifampicin, clofazimine will cause pink or red color urine, but not this chloroquine. Chloroquine, it will cause brown colored urine. Right, so chloroquine, this will cause the brown color urine, right? Whereas the first three options, they are associated with pink or red color urine. Now if you see the colors of the urine, in case of desferoxamine toxicity, the urine color is pink. Whereas in Serratia marcescens infection, you have what is called pink diaper sign. In clofazimine, porphyria or myoglobinuria, it will be red urine. And hematuria, you will have cola colored urine, and hemoglobinuria, you will have black colored urine, and in alkaptonuria, there will be black color urine on exposure to air. So this is about the color of the urine. This is about the color of the urine. Okay. Next question on the urine analysis: the stain that is used in the evaluation of the eosinophiliuria. Steinheimer and Malbin stain, right and Hansel stain, hematoxylin and eosin stain, Steinheimer stain. So please remember, first of all, you need to know where is this scenario eosinophiluria will be there. Eosinophiluria is observed in patients with atherosclerotic diseases. That is number one. Next, in patients like allergic interstitial nephritis, there will be, right, allergic interstitial nephritis, there will be eosinophiluria. And the stain that we use for evaluating the eosinophiluria will be right and as well as the Hansel stain. Whereas the Steinheimer and as well as Malbin stain, it is used to stain the urine sediments. Right, urine sediments, all right. And this hematoxylin and as well as eosin stain, this is a regular stain used in histopathology slides. Right, used in the histopathology slides, right? Whereas the Steinheimer, as I have just said, that is used to stain the urine sediments. Okay, So the conditions where you will have the presence of the eosinophiluria will be atheroembolic diseases, allergic interstitial nephritis, and then right and as well as the hand cell stain. Okay, so this is about the questions related to the urine analysis. Then the next set of questions will be on the topic of nephritic and as well as the nephrotic syndrome. So we have a 65-year-old male came to the outpatient department with complaints of the foamy urine. Examination showed puffy eyes, pedal edema, and increased blood pressure. Further laboratory tests showed presence of fat bodies in the urine, and urine protein is more than 2 grams per gram of urinary creatinine, and urine protein electrophoresis reveal albumin. Identify the diagnosis and mark the option with appropriate kidney biopsy changes on the electron microscopy. Effaced podocytes, subepithelial deposits and as well as spikes, podocyte vacuolization, and then effaced podocytes. So the age of the individual is 65 years. Okay, so 65-year-old man, that is first point. And the proteinuria is more than 2 gram per gram of the urinary creatinine. Right, the proteinuria is like more than 2 gram per gram of the urinary creatinine. So which clinical condition where you have the proteinuria of more than 2 gram per gram of creatinine, and that too in elderly individual, is it is a case of nephrotic syndrome secondary to membranous glomerulonephritis. Right, secondary to membranous glomerulonephritis. Now, in patients with membranous glomerulonephritis, what is that you will have on electron microscopy is you have the presence of subepithelial deposits and as well as spikes. Right, subepithelial deposits and as well as spikes. Whereas effacement of the podocytes, this is observed in minimal change disease. Okay, so in minimal change disease, you have the presence of the effaced podocytes, and the subepithelial deposits and as well as the spikes, they are the one which you observe in patients with membranous glomerulonephritis, and podocyte vacuolization is present in focal segmental glomerulosclerosis, and focal segmental glomerulosclerosis is observed in adults of age group up to 40 to 60 years, whereas minimal change disease, it is observed in children. And in focal segmental glomerulosclerosis, you will not only have podocyte vacuolization, there will be detachment of the podocytes, and there will be effacement of the podocytes also in case of focal segmental glomerulosclerosis. And in minimal change disease, the effaced podocytes, right, the effaced podocytes, they are mainly because of loss of membrane polyanion, that is heparan sulfate proteoglycan. Right, that is heparan sulfate proteoglycan. So that is where you will have the presence of the effaced podocytes. Okay, so the answer here is subepithelial deposits and as well as the spikes. Right, the next question. A 10-year-old boy presented to the outpatient department with a complaint of puffy eyes, swelling in the scrotal area, abnormal weight gain in the past 10 days. Investigation showed the normal blood urea nitrogen or creatinine and increased 24-hour urine protein. Kidney biopsy revealed normal light microscopy and podocyte effacement on electron microscopy. Identify the disease and its management. The options are steroids, angiotensin receptor blockers, furosemide, and then the sodium nitroprusside. So 10-year-old boy presenting with the elevated 24-hour urine protein. Where do you observe this? You observe this in patients with minimal change disease. So minimal change disease, it is a clinical scenario where the patient will have the nephrotic syndrome with proteinuria of more than 2 gram per gram of creatinine and predominantly albumin, causing hypoalbuminemia, resulting in the development of puffy eyes and as well as pedal edema. Alright, now identify the disease, that is minimal change disease. What is the drug of choice? The drug of choice will be the steroids, right? And among the steroids, like what we give is the prednisolone. Right, among the steroids, what we give is the prednisolone. Okay, so prednisolone is considered as the drug of choice, and this particular prednisolone, we give it for nearly around 8 weeks. Right, we give it for nearly around 8 weeks. Okay, and in which 4 weeks we give 1 to 1.5 milligram per kg body weight, and the remaining 4 weeks right? And in the remaining 4 weeks, we give in a tapering dose. We give it in tapering dose. And whenever we are tapering, if there is again development of minimal change disease, that we call it as relapse. So whenever there is a relapse, again we start steroids and we continue steroids. But this particular steroids, when we give it for long term, that is associated with the toxicity of the steroids, where the individual develops 𝐒𝐮𝐻 syndrome, right? And now, how is that you can avoid the development of the 𝐒𝐮𝐻s? We need to stop the taper and stop the steroids, and you should give alternative immunosuppressants. And these alternative immunosuppressants will be cyclophosphamide or levamisole, right? Cyclophosphamide or levamisole. Then that is in steroid dependent. So this we call it as steroid dependent nephrotic syndrome, because whenever there is tapering of the steroids, there is a relapse. That is steroid dependent nephrotic syndrome. But some patients, they don't respond to the steroids also. This we call it as steroid resistant nephrotic syndrome. In steroid resistant nephrotic syndrome, the drugs that we give is cyclosporin or tacrolimus, right? Cyclosporin or the tacrolimus has to be given. Okay, so this is about the story related to the treatment of the minimal change disease. So in minimal change disease, the drug of choice will be the steroids. The drug of choice will be steroids. Okay, next question. And in minimal change disease, light microscopy will be normal. Electron microscopy is the one which will show you that there is the effacement of the podocytes. Okay, next question. A 20-year-old male patient came to the hospital with complaints of the extreme headache and dark brown colored urine for the past 10 days. The patient has a history of antibiotic therapy for his sore throat 3 weeks back. A kidney biopsy shows a 𝗪𝐸𝐵𝐞 appearance in an immunofluorescence study. Which of the following is the diagnosis of this condition? Post-streptococcal glomerulonephritis, Buerger's disease, IgA nephropathy, focal segmental glomerulosclerosis. Okay, so now you see the patient had the 10 days back, right? The patient had the sore throat, and the kidney biopsy is showing the 𝗪𝐸𝐵𝐞 appearance, which is very much suggestive of the post-streptococcal glomerulonephritis. So kidney biopsy showing 𝗪𝐸𝐵𝐞 appearance, that is post-streptococcal glomerulonephritis. Lymph node biopsy showing 𝗪𝐸𝐵𝐞 appearance, that is seen in case of the Burkitt's lymphoma, right? And CT brain showing 𝗪𝐸𝐵𝐞 appearance, that is observed in case of the neurocystic right? And USG abdomen showing 𝗪𝐸𝐵𝐞 appearance, that is observed in case of the acute viral hepatitis B infection, right? Acute viral hepatitis B infection. So the answer to this particular question is what? That is post-streptococcal glomerulonephritis. Whereas in case of Buerger's, which is nothing but the IgA nephropathy, what does the electron microscopy show? Electron microscopy shows that there is proliferation of the mesangial cells, and there is mesangial and paramesangial deposits will be there in case of this Buerger's or IgA nephropathy. Whereas you take focal segmental glomerulosclerosis. In case of the focal segmental glomerulosclerosis, the electron microscopy shows the presence of the effacement of the podocytes. There is vacuolization of the podocytes, and there is detachment of the podocytes. Okay, so that is what you will observe in case of the focal segmental glomerulosclerosis, right? But electron microscopy or the fluorescent microscopy showing 𝗪𝐸𝐵𝐞 appearance, it is observed in case of post-streptococcal glomerulonephritis. And in post-streptococcal glomerulonephritis, the treatment is symptomatic management. We don't have any specific drug that has to be given in the treatment of PSGN. And how is the prognosis in PSGN? They have a good prognosis. Recurrence is very rare in PSGN, and the ASO titer are being elevated. Whereas in IgA nephropathy, recurrence is very common and ASO titer is not elevated, right? In case of IgA nephropathy. But in IgA nephropathy also, they will have the past history of your upper respiratory tract infection. But that upper respiratory tract infection will be there only just 2 to 4 days back. So just 2 to 4 days back, there will be history of upper respiratory tract infection in case of IgA nephropathy or the Buerger's disease. Okay. Next question. all of the following are the findings of the Buerger's IgA nephropathy except renal function tests are normal, blood pressure is normal, C3 is normal, 3 weeks history of sore throat infection. In patients with IgA nephropathy, renal function tests are normal. Why renal function tests are normal? Because in patients with IgA nephropathy, the glomerular capillaries are normal. Right? The glomerular capillaries are normal. So renal function test will be normal. Blood pressure is also normal. C3 is also normal. Right? But they will not have 3 weeks history of sore throat. Right? They will be having 2 to 4 days history of sore throat infection. Okay, so that is about your IgA nephropathy. They will not have 3 weeks history of sore throat infection is observed in patients with post-streptococcal glomerulonephritis. And in IgA nephropathy, what is that you will observe? You will have mesangial proliferation on the biopsy. That is the reason why it is also called mesangial-proliferative glomerulonephritis, and the treatment that you need to give is steroids in case of IgA nephropathy. Whereas there is no role of steroids in case of the post-streptococcal glomerulonephritis. And these are some of the differences between PSGN and as well as Buerger's. PSGN, history of weeks of sore throat or skin infection. Whereas short history, 2 to 4 days past sore throat infection in case of Buerger's. Renal function tests are deranged in PSGN, normal in case of Buerger's. Blood pressure is increased in PSGN, normal in case of the Buerger's, or it may be slight increased. And serology will be positive. The antibodies are elevated, whereas the antibodies and C3 levels will remain normal in case of Buerger's. And C3 levels will be decreased in PSGN. There will be transient decrease, and followed by that, the C3 levels will return back to normal within 4 to 8 weeks. So that is what you observe in case of post-streptococcal glomerulonephritis. Okay, so that was the questions related to the nephrotic and as well as the nephritic syndrome. Next is the question related to the renal artery stenosis. So we have a 52-year-old female patient present to the nephrology clinic with complaints of fatigue, muscle weakness, and occasional palpitations. She has a history of poorly controlled hypertension despite being on medication. An ultrasound examination of the kidney reveals a symmetrical kidney with one kidney appearing smaller in size while the contralateral kidney appears enlarged. Which of the following is the most common cause contributing to the patient's symptoms? Atherosclerosis, fibromuscular dysplasia, Takayasu arthritis, and then the polyarteritis nodosa. So the answer in this question is the atherosclerosis. Why? Because first point, the patient is having poorly controlled hypertension. That is one point. And there is asymmetrical kidneys. Right? There is asymmetrical kidneys with one kidney appearing smaller in size, whereas contralateral kidney appears enlarged. Which of the following is the most common cause contributing to the patient's symptoms? So now, in which scenario there will be asymmetrical kidneys with hypertension? Asymmetrical kidneys with hypertension is observed in case of the renal artery stenosis. Now, in elderly individuals, what is the most common cause for renal artery stenosis? That is atherosclerosis. Whereas fibromuscular dysplasia, it is very common cause for renal artery stenosis in young individuals, and that too in the Western population. Whereas Takayasu arthritis, it is also the most common cause for renal artery stenosis in young individuals, that is in India. And these patients, they will be having hypertension, and because of hypertension, they will be complaining of the severe headache. Right? They will be complaining of the severe headache. Okay. And the next important point is these patients, they have recurrent flash pulmonary edema. Right? There will be recurrent flash pulmonary edema. And how is that you will treat this flash pulmonary edema is you need to give 1 dose of diuretic, the pulmonary edema will get completely cleared. So that is how you treat the patients with renal artery stenosis with pulmonary edema. 1 dose of diuretic will clear the entire pulmonary edema, and that is called flash pulmonary edema. And how will you diagnose? The first line investigation will be ultrasonography, and the confirmatory test you can do is the renal angiography. And the treatment is unilateral renal artery stenosis, you can give the ACE inhibitors. Whereas for bilateral renal artery stenosis, the ACE inhibitors are contraindicated, you need to give calcium channel blockers. And if the patient develops fibromuscular dysplasia, or if the patient develops the flash pulmonary edema, that is the point when you need to do a PTRA, that is percutaneous transluminal renal angioplasty, right? Percutaneous transluminal renal angioplasty. So the answer in this particular question is the atherosclerosis, right? So this is the discussion related to renal artery stenosis. So the next question for the discussion is on the topic of renal tubular acidosis. So the question is, we have a 50-year-old patient with history of scleroderma and recurrent kidney stones, complaining of muscle weakness and metabolic acidosis, prompted further evaluation. Laboratory results reveal hypokalemia and nephrocalcinosis. Which type of renal tubular acidosis is this patient manifesting? The options are type 1, type 2, type 3 and type 4 renal tubular acidosis. So this particular individual is having two important abnormality. One is hypokalemia, the other one is nephrocalcinosis. So hypokalemia and nephrocalcinosis, these two are the features of the type 1 renal tubular acidosis. Whereas in type 2 you will have hypokalemia, and in type 4 you will have hyperkalemia, but both in type 2 and type 4 you will not have renal stone formation. Whereas type 3, it is very rare or does not exist at all. So the pointers suggestive of the type 1 renal tubular acidosis is hypokalemia and nephrocalcinosis. And what exactly is the pathology in type 1 renal tubular acidosis? The pathology is at the level of distal tubules, where there will be failure of, right, where there will be failure of the H plus ion secretion, right, failure of the H plus ion secretion in the distal tubule, right, failure of the H plus ion secretion in the distal tubule. That is what is your type 1 renal tubular acidosis, okay? And in the place of the H plus, the K plus will be secreted into the tubule, and that will get excreted out and resulting in the hypokalemia. And these patients, they will have hypercalciuria, and this calcium will accumulate in the form of the renal stones. But renal stone formation is not observed in case of your type 2 and as well as type 4. And the treatment that you will be giving in case of the type 1 renal tubular acidosis is, you need to give the sodium bicarbonate, right? And this particular sodium bicarbonate, it is the oral sodium bicarbonate is what you need to give. And the dosage of the oral sodium bicarbonate is around 1 to 2 milliequivalents per kg, right? 1 to 2 milliequivalents per kg. That is the dosage of the oral sodium bicarbonate, all right? So that was the question on the topic of renal tubular acidosis. And one more question. A 55-year-old male with history of poorly controlled diabetes mellitus presents to the emergency department with weakness, palpitations and muscle cramps. Laboratory test reveals hyperkalemia and metabolic acidosis. Further investigation confirms the diagnosis of type 4 renal tubular acidosis. Which of the following treatment options would be appropriate to manage the underlying electrolyte abnormality in this patient? The options are fludrocortisone, dietary potassium restriction, furosemide and sodium bicarbonate supplementation. Now, in case of the type 4 renal tubular acidosis, what exactly will be the problem? The problem in case of type 4 will be either aldosterone deficiency, right? Either aldosterone deficiency, or there will be aldosterone resistance, right? So that is the problem in case of the type 4 renal tubular acidosis. And because of the aldosterone deficiency, the potassium does not get excreted out, and this will result in the hyperkalemia. Now, in case of type 4 renal tubular acidosis, you need to give a drug which is an aldosterone analog. Among the options, like, what is the answer? It is the fludrocortisone. Fludrocortisone, it is an aldosterone analog, all right? And dietary potassium restriction, definitely this is also very much required, but the most appropriate to manage the underlying electrolyte abnormality will be your fludrocortisone. So fludrocortisone will be acting as an aldosterone analog, and that is the one which will be responsible for the potassium excretion where the patient is having the hyperkalemia. And furosemide, yes, even that will also cause kaliuria. And sodium bicarbonate supplementation is also required, but the question asked is most appropriate. So the answer here is the aldosterone analog, and that particular aldosterone analog is the fludrocortisone. All right. So after having discussed about the questions on the topic of the renal tubular acidosis, let me take up the discussion of the syndromes. So we have three important syndromes: Gentleman, Barter's, and as well as the Liddle syndrome. So you need to match which are the abnormalities in these three syndromes. So you take the Gentleman syndrome. In patients with Gentleman syndrome, it resembles thiazide diuretics, and the defect is in the sodium chloride co-transporter, and not only that, there will also be defect in the TRPM6 transporter. So the TRPM6 transporter, it is required for magnesium. Okay, it is required for the magnesium secretion, and the TRPM6 transporter gets affected in these patients with the Gentleman syndrome. So 1B. Then you take this Barter syndrome. In case of the Barter syndrome, the very important point is there will be sodium. This will resemble the thick ascending limb of loop of Henle. That means it will resemble the loop diuretics. All right. So sodium potassium 2 chloride co-transporter and the chloride channel and ROMK defect will be there in case of the Barter syndrome. So this will resemble the loop diuretics. Whereas you take the Liddle syndrome. So in case of Liddle syndrome, there is gain of function of the ENaC. Right? There will be gain of function of ENaC in case of the Liddle syndrome. So in first two, that is in Barter syndrome and as well as in Gentleman syndrome, the blood pressure will be normal. Whereas in Liddle syndrome, these patients will have hypertension. Right? In Liddle syndrome, these patients will have the hypertension. All right. So now 1B, 2C and 3A. Okay. So the correct answer is B. And in case of the Barter syndrome, the drug of choice is indomethacin. Whereas in Gentleman syndrome, you need to give symptomatic management, or you need to correct the electrolyte abnormalities. And in Liddle syndrome, the drug of choice is the ENaC blocker, that is amiloride to be given, or the alternative drug is the triamterene. Okay. And I'll just show you one important table of differences between Barter syndrome and the Gentleman syndrome. So both of them, the Barter's and as well as Gentleman's, it is autosomal recessive type of the inheritance, whereas Liddle's, it is autosomal dominant type of inheritance. And abnormality in case of Barter's will be over the sodium potassium 2 chloride channel, whereas in Gentleman syndrome, the sodium chloride co-transporter. The age of presentation early in life in Barter's, whereas in Gentleman's late childhood or early adulthood. And in both the scenarios, the blood pressure will be normal, right? There is no polyuria. And in both of these individuals, there will be polyuria present. And next is the neuromuscular symptoms are uncommon or mild in case of the Barter syndrome. They often present with sensory neural hearing loss, triangular faces with drooping mouth, large eyes and pinna, and renal failure in Barter's. Whereas in Gentleman's, they often present with neuromuscular symptoms such as muscle cramps, spasms, and significant fatigue. That is what you observe. And in both of these patients, you should understand why there is neuromuscular symptoms. These neuromuscular symptoms are mainly because of the hypokalemia. And both of these patients, they present with metabolic alkalosis, right? And that too, the chloride resistant metabolic alkalosis. And if you take the magnesium level, because there is TRPM6 that is being defective in patients with the Gentleman syndrome, the absorption of the magnesium across the TRPM6 will not be there. That will result in hypomagnesemia. Whereas in case of the Barter syndrome, the magnesium levels, they remain normal or maybe even low, right? Maybe normal or even low, right? And next is there will be increased urinary calcium excretion in case of Barter's, whereas there will be decreased urinary calcium excretion in case of the Gentleman's. So that is the reason why you will have hypocalciuria. So there is no risk of renal stone formation in Gentleman's. but in case of the Barters there is hypercalciuria, there is increase in urinary calcium, and that will result in increased risk of the nephrocalcinosis. And you take the PgE2 levels. The PgE2 levels are increased in case of Barters. Because the PgE2 levels are being increased in case of Barters, that is the reason why the drug of choice is indomethacin. Alright, next question. Okay, now you need to know the treatment of these syndromes: Gentleman, Barters, Liddle's, and as well as the cons. So Gentleman's, as there is no particular treatment, right? Symptomatic management. Bartter syndrome, like you need to give indomethacin. Liddle syndrome, you need to give amiloride or the triamterene. And the Con syndrome, you need to give the spironolactone. So DCAB, right? So the answer here is B. So these are the questions related to the syndromes. And one more important syndrome that you need to be completely aware of is the Alport syndrome. Okay, so if you take this Alport syndrome, in case of Alports, the abnormality is in the alpha 5 chain of type 4 collagen. Right, the abnormality is in alpha 5 chain of the type 4 collagen. And this Alport syndrome is characterized by a triad, right? The kidney abnormality will be in the form of glomerulonephritis. And what is the most common extrarenal manifestation is the sensory neural hearing loss, right? Sensory neural hearing loss. And then followed by that, you have ophthalmic manifestation. And this ophthalmic manifestation will be in the form of anterior lenticonus, right? Anterior lenticonus, okay? And this anterior lenticonus is that which will present as increase in the anterior curvature of the lens, and thereby these patients will have the cataract. There will be also xerosis and as well as the cataract. So that will be the presentation in case of the ophthalmic manifestation, that is anterior lenticonus. Okay, so this is about the syndromes that you will have in case of nephrology. Okay, so these are the questions in the topic of the nephrology. Thank you very much.